we see patient in a very holistic way rather than just looking at their organs or disease states. We look at them and try to relate to them as another human being who comes in with different background, experience, relationships, aspiration, and we do our best with limited amount of time that we have with our patients to be able to really understand what their needs are, and as a clinician be able to meet those needs beyond just trying to address their disease.
The Division of Collaborative Care and Wellness here in the Department of Psychiatry at the University of Rochester Medical Center was founded in 2016 with the specific aim to support the design and implementation of programs and services that are at the interface between psychiatry and general medicine. The biopsychosocial model emphasizes the importance of the psychological and social importance in the care of the patients.
In the Medicine and Psychiatry Division, our work really is related to improving the care and the lives of patients with severe psychiatric conditions, such as schizophrenia, schizoaffective disorder, bipolar disorder, just to name a few. We are well aware that these patients live approximately 20 years less than their similar age cohort and usually succumb to common medical conditions that potentially could have been treated earlier on. Patients with severe mental illness have a confounding number of psychosocial issues that are important in treatment planning and to prevent readmissions and really to diminish morbidity and mortality.
So Proactive CL is a model of care in delivering CL services in a medical hospital. Essentially, it's collaborative care in the hospital setting. This way, what we're doing is essentially we're systematically screening for mental health needs for patients who are admitted to medicine. The other is integration. And so we're working in collaboration with our medical colleagues, nurses, and other staff on these medical units. Over the years that we've been implementing the service, we've actually been doing a couple of different team compositions, if you will. So starting with a psychiatrist, a nurse practitioner, and a social worker. We're currently looking at having behavioral analysts on our service to meet the needs of the patient population that we're serving. We are actively evaluating service metrics. And so we actually are currently at the end of a 2-year QI implementation grant where we're evaluating kind of a full range of service metrics, looking at, are we getting to people sooner? What is the volume of consultation? What are the mental health needs of this population?
We have a strong history of collaboration in psychiatry and neurology that dates back almost half a century. But over the years, I've certainly felt that the mental health care needs of our patient population in neurology is just enormous. And there was great opportunity to realize the vision of Dr. Engel in the biopsychosocial model of care and to really truly create a biopsychosocial home in neurology.
The work I'm doing with neuroimaging and chronic pain is trying to answer two basic questions. The first question is that we are trying to understand how does the brain turn nociception, so the activation, if you want, of pathways that carry potentially painful information into an actual conscious pain experience. So we don't know how the brain really generates the experience of pain. So that's the first question we're trying to work on, and everybody in the field of neuroimaging is trying to work on. The second main objective of my research is to understand how the pathophysiology of chronic pain from the brain point of view. How does the brain change with chronic pain? Are these changes before chronic pain? Do they develop as a result after the fact? A patient becomes a chronic pain patient and then their brain changes. And these questions matter a lot because if there are predictors of pain or of chronicity of pain, we can use that to predict the future of a patient.
The University of Rochester Medicine Physician Communication Coaching Program is a program to help physicians through their lifespan further develop their communication skills for their own satisfaction, but also for the satisfaction of patients, families, their teammates, their colleagues, their research participants. I think it increases the physician's patient satisfaction scores immediately, and they're so happy that the Strong Memorial Hospital or the university has a program like this, because as you know, patients complain about their physicians not listening to them, etc. So, I think it works actually for both.
What I would like to see is more integrated services in a larger number of primary care sites, in a larger number of specialty sites, in the hospital setting as well as outpatient setting, as well as on a community and population health level.
I think the future of the program and of healthcare is innovation. We need to keep pushing the boundaries so that we can be able to meet our goals of delivering or improving the care of people with severe mental illness. As mentioned many times, there's a disparity in care in this patient population, and what we hope for is by having these services that we can begin to chip away at some of the inequities that they find in their healthcare needs.
It begins with our foundational belief that there is no health without mental health. In addition, we also believe the opposite as well, in that sense that we believe there is no mental health without physical health. So in other words, that we try our best to also address the physical needs as well as mental health needs while being able to address the whole person.